Yeah. Right.
I don't.
Okay. It's the meeting like it's 5 o'clock, so let's call this meeting to order. Public Hospital District Number 1, regular meeting. It's September 28th. Andy, would you mind doing a roll call, please?
Sure. Matt Altman,
Here.
Bob Davis.
Here.
Terry Clark,
Here.
John Ward,
Here.
Eric Lebanel. Here. Julie Peterson. Here. Scott Olander.
Here.
Jason Adler.
Here.
Dee Utley. Here. Stacy Alea. Here. Mandy Olson. Here. Dr. Martin.
Here.
Cindy Kelly. Here. Suzette. Here. And I'm sorry, you're gonna have to remind me.
I'm Carolyn McCain.
Carolyn McCain, thank you.
Director of Respiratory.
Welcome.
Brand new.
And then it looks like online or on Zoom, we have Jeff Yamada
Here.
and Dr. Hoppy,
Here.
Michelle Whirl,
Here.
Dr. O'Brien,
Here.
and then there's one that says Kevin.
That's me.
Oh, okay.
Okay.
Here's Kevin.
All right.
Oh.
Thank you, Mandy.
Yeah.
So first up, approval of agenda. Are there any changes or additions to the agenda?
To approve the agenda.
Motion from John,
Second.
second from Terry. Those in favor, please say aye.
Aye.
Thank you. Next up, we have the consent agenda. You have the minutes from the August 24th meeting, the approval of checks, the foundation report, finance committee minutes, and then QI council minutes from April and June. Just note one quick thing that at the next QI council meeting, I talked with Mandy about this. We're going to talk about what sort of minutes or shouldn't be included in the board packet from now on, since some of this is confidential material. So we're going to talk about how to manage that in the future. Thanks, John, for calling our attention to that. Just thought I'd mention that.
And then on page 3 of the consent, which is page 5 of the packet, I made an error on when I approved the minutes. It goes from 8 to 10. There's no 9 listed. So I don't know if that's something we want to deal with, or just note that we did catch it before we officially published it.
Yeah, I think since that's a typographical error, I think we can correct that and then approve the consent agenda as amended. Thanks for catching that, John. Any other changes or anything to the consent agenda?
Would that have been a reference to executive later?
Yeah, I think it's because we didn't have a presentation. I think things shifted and we just missed the shuffle. So.
Any other changes to the consent agenda or anything anyone wants to hold? Okay, motion to approve consent agenda.
So moved.
All right, Bob,
Second.
second from Erica. All those in favor, please say aye.
Aye.
Yes, thank you. Next up on the agenda is public comments and announcements. If you have a public comment to make, please begin by stating your name and where you're from, and try to keep it to 3 minutes if possible. And keep in mind that the board does not respond during the meeting to these comments, but we take them seriously and we will consider them at another time more fully. But are there any comments or announcements at this point? Okay, hearing none, we'll proceed then. Thank you. First up then, we have a presentation. Suzette Johnson, Compliance Specialist, Cynthia Kelly, Director of Health Information Management, to talk about the compliance work plan.
So I'm here to kind of give you a report on what we've been doing so far this year. Started out the year with myself and Suzette coming into compliance. And so we've done a lot of work since then, starting with compliance policies and procedures, not just compliance, all policies and procedures. We are in the process of implementing a new application that will help us manage these better and hold everyone to the expectations for the reviews of those documents. And the application is called LucidDoc. Implementation underway. We're hoping to roll it out to everyone. I'm hoping by the end of October. There's a few little things that are kind of holding us up right now. But it's sounding after a meeting today, it sounds like by the end of October, we should be able to roll that out. So that's going along well. Yes, so this is our biannual report here in September. We are going to be, we do report out to the board quarterly, basically looking at certain benchmarks to see how we're doing with compliance issues. Can you roll up? So far we've had, this year we've had 15 reports, 15 things brought to our attention to research and investigate. 5 of those have been substantiated and 3 of them are still under investigation. So we'll continue to do work.
Are the 3 included in the 5? Are they a subset of the 5, or is it 5 that have been substantiated and there's 3 more that you're still reviewing?
There's 5 substantiated.
Okay.
Although you probably can't go into a lot of detail, can you give us a sense of the kind of stuff that's included in the substantiated?
Sure. Well, we've had some questions about some charges, and the charges are actually accurate. There's a difficulty with the description that's showing up on the statements. We thought we had it fixed, and we found out recently, no, it's still not fixed. It's finding the right thing to change, and so I think now we've got that.
All right.
That's been the main things that have been substantiated.
All right.
Does that get routed through Cerner? Is it a Cerner fix or?
It is, it's a bill in Cerner for the charges and how they show up on the statement. We are working to make sure that everyone knows about compliance by having training on our code of conduct and compliance policies through BIS Library. And we verified that all that has gone out. All employees are tasked to read those policies in BIS Library. We also have been watching to see how we're doing with fishing. Are we catching that? We had a fish prone rate that was high to begin with, of course, because we were just learning about it. And the goal was to be less than 5%. By December this year, we hit that in June, actually, we were at 4.7%. So that's been going really well. We get some really good data back from the program that monitors that. We also do new employee and leader education and compliance, and that's an ongoing thing that we do. Let's see here. One of the things we have available is a call line, a hotline for anyone who wants to report a compliance issue. We've only had 1 call this year so far. And unfortunately, it was anonymous and there was very little information. So there was really nothing we could do to respond. We didn't even know who to respond to. And there just wasn't enough information even to investigate. When we do investigations, we do report out to the compliance committee each month. We're looking at the numbers and how many compliance issues there's been and how many were substantiated. So we do that on an ongoing basis. And we also make sure that employees are aware of any kind of policies and procedures that promote awareness of compliance. And that's being done through the assignments in BIS Library, and they have access to Lippincott. And that's still available. And then we do some ongoing auditing and monitoring. Right now, one of the things we're looking at very closely is our contracts, and that's going to be part of the LucidDoc implementation that we're working on right now. We hope to have much tighter, much better oversight of that, the contract, the whole thing, how it's done. Okay. Again, we still do the security risk analysis. Jeff's team takes care of that. It's an ongoing thing. And we have the 340B internal audits that are ongoing. Anytime we detect any kind of privacy breach, that is always reported if it's at the level that requires it to be reported. So far, we've had one this year. I need to add that. Sorry about that. It's an oversight on my part. Taking me a lot. And these are just some additional things that we've done. These are things that weren't really on our work plan, but I just wanted you to be aware of it. We also we check with HR, our accounting and medical staff. Because one of the requirements is that anyone that's new to the organization, we do a background check. We look to see if they've been opted out for any reason. And we verify that is going on and respond. If there's something we need to respond to, that's being done appropriately. Let's see. Oh, okay. So we do get regulatory updates through the Rural Health Collaborative. It's really helpful. They have an attorney that works with them, and anything that comes along, he sends that out to us, and I forward it to anyone who needs that information. So it's an attempt to keep people aware of the regulations. Equipment recalls is another thing that's done through material management, and that's happening and it's current. And we're working right now on developing an assessment to determine the effectiveness of the compliance program. We're using the OIG's guidance on questions you can ask, things you should assess for, and we've got that started. And we'll be finishing that by the end of this year, and those findings will be part of our work plan next year. I did want to let everybody know that Compliance Week is the first week in November, and we've got some plans for that. Suzette and also Justin, who's working with us as a contract management specialist, have been working real hard on that. I think we'll have a lot of people be a lot more aware of compliance and get involved in it on a different level. And also let you know that we did some compliance training. Suzette and myself went to an academy in June, and that was really informative and really helpful. And I was able to take the exam and get the certification in healthcare compliance. So, and then Suzette's plan is to go back.
That's great.
Suzette's plan is to go, she's not really eligible until the first part of next year, so.
I'll say that compliance certification is very rigorous. They have higher standards of in-person continuing education than some of the other certifications I know of. So that's a tough one to get.
Thank you, guys. And I think that concludes my presentation.
I think that's right.
Yeah. Any questions? Anything I could answer?
John, you're the, am I right? You're the board representative on the compliance?
Not as of last
I
year.
am.
You, Terry? Okay. Do you have anything to add to the?
No, she is very compliant, and consequently, the reports we have at the compliance meeting are very good. And she goes over all the things, and she asks a lot of really good questions to the people that are reporting compliance things. So my analysis is that she helps the hospital be very compliant.
All right.
So I really want to thank you for being such a compliance wonder.
All right. Well, thank you. Yeah, thanks for the presentation. Any questions?
I like the activities planning to bring awareness to people who aren't necessarily in the depth that you are all the time. So forward to seeing what comes up in announcements or whatnot for that.
Thank you. Yeah, you'll be seeing some things. I've got big plans.
Thank you so much for sharing.
Thank you.
Thanks, Sid.
Thank you.
Oh, just one other thing. One of the biggest compliance things that is at that meeting is the thing about fishing. Because we're doing a really good job. Our fishing instructor, our IT director, is doing a really good job preventing the hospital from being hacked or anything else like that. And so I've kind of researched other places doing it, and we're doing a lot more work on our fishing importance. So that is very important that we don't get hacked.
All right. All right. Thank you very much. Appreciate it. And thank you, Suzette. for coming.
So, Matt, can I introduce Caroline?
Yes, please.
So after decades of Jim Allen being at the helm of cardiopulmonary and respiratory, and Caroline, you're going to have to remind me of your last name. McCain comes to us with a wealth of experience from the lower valley, a couple years most recently. Can you just share kind of your background? And then I know you have some real vision for our cardiology program.
I do, actually. I'm really excited about this. I really wanted to come here after coming and interviewing here, which I just do in my career, to do it regularly, to stay, fresh. So when I came here, I was so impressed with this hospital and everybody in it. From the front door on, everybody I met was just great. And I will tell you, as an example, I was walking into Safeway and the lady says, "Good morning." I was thinking, okay, who is she talking to? I'm looking around. I'm going, "Good morning," I'm not used to that. Where I come from, the East Coast, where it's very populated. I mean, Virginia Beach, Virginia. So I'm really excited to be here. I'll stay on track now. I get off real easy. About the changes that are going to take place in the cardiopulmonary department. I know we've got some moves coming up. I know there's been talks of expansion, which I'm really excited about. And the staff is just, I'm so impressed with the whole place. I really am, from the front to the back, to the cafeteria. It's just, I think this is really going to be good, because we're going to be able to meet a lot more needs of the community, which is what our mission is. I did have a staff meeting last night. We're reviewing that mission on a regular basis so that we really, why are we here? Why are we doing this? What do we want to accomplish? So I'm really excited. I do have a couple years, probably a couple decades in there of a lot of experience. I actually was with Astoria Health down in the Valley for 4 years, and I lost my parents and then moved back to Virginia to be with family. So originally from Wyoming, small town, this is very similar to that, where people say hello and speak to each other, and so I'm loving it.
Well, let me just share, one of the reasons we're so excited to have Caroline accept the position here is, we will be asking you to approve, as part of the QAPI, work on our cardiopulmonary in the clinic and in the hospital, that entire service line. And one of the things we're challenging ourselves to do is to make that seamless to the patient. Right now, it's kind of business over here and business over there. And we have a tendency to behave like a clinic and a hospital. I don't think we're maximizing our providers over there. Everyone loves Dr. Hoppy. I think she's 90 days out for a new so we need to create more bandwidth. And when we explained to Carolyn what we were trying to do, she goes, know it, done it. So when we were working on the QAPI the other day, she threw elbows to the front of the room and started putting some ideas up there. So I'm really enthusiastic about her vision for that service. And we know how much the community needs it. So what a find.
Absolutely. And on that thought, I was very fortunate at a very young age to have a best friend who was a Joint Commission surveyor. I have written PI programs, QI, QC, QA, you name it. I've done it for other companies, and actually surveyed other companies, home care companies, and worked, always taking this meeting, what I've already done, building on it, and educating my staff so that they're on board too. They're excited too. I'm really happy about that. But thank you so much. I don't want to be disrupting, and I'm going to excuse myself because I'm going to go down and catch my night shift. I'm learning where his stuff is, because I find myself to learn.
Well, thanks so much for coming up to see us. Appreciate it. Okay. Thank you, Julie, for this. Okay, next up, we have reports and dashboards, and we'll start with quality. Yes.
Packet starts on my report. 23, page 23. So I'm happy to take questions. I do have a patient story to read, or a patient letter.
Description of the coffee process is something that we mentioned at the last board meeting about how it's going to be slightly changed from what you're used to. But I think it's a really exciting change.
At our session on Monday, and I think it was really exciting. It was really nice to get all together in a big room again. And I heard some comments from people going away from it saying, this is the things we want to work on. This is the work we want to do. And so that makes me really proud that the QAPI will be so meaningful, I think. So
You know what I loved about that meeting is we totally lost control of it. They got up with their stick and they just went right to work.
the
And
agenda did get blown up.
they moved the agenda up and it was. and
Because we were excited, because it's moving, it's happening.
Yeah, so it was a great meeting facilitated by Mandy. The work that she does to bring us to a moment like that is huge. So, but it was.
And to see so many new leaders just feeling really confident and supported and throwing their ideas out there or getting involved and not feeling like they were going to be shot down or that they had to be perfect. It really felt collaborative and it's exciting.
So the one thing really great about coffee is I'm on the governance board committee for Washington State Hospital Association. At our last meeting, we were doing safety and quality, and I discussed a lot of things. And I mentioned our coffee is something that the board needs to see because we oversee a lot of quality and improvement. And some of the people on the governance board weren't familiar with coffee. And so they liked it. And so it sounds like the coffee is going to be increased in some other organizations. So the board will understand it. So that's how important it is.
Well, their organizations will be surveyed to that as to like whether their board knows about it and talks about it in the board meetings. And it's really obvious in our board meetings how important it is. So they'll be told if they don't start doing it.
Well,
Right,
and
surveys.
I even mentioned to them that having the board know about coffee would be something which they should add to their coffee, because having the board understand quality and the improvement that the coffee does would be another coffee to increase the board doing that. So that is very true.
One question I had for you about your report, Andy, was this hospital acquired infection that may not have been acquired in the hospital. Right?
Yeah,
Could have resulted from showering after discharge.
So there's some technical definitions where it's like, is this, do we have to claim it or not?
Yeah.
And so sometimes, yeah, you're highly suspicious that it didn't receive it from the time of surgery here.
Sure.
But we still have to like take credit for it.
Okay.
Which is a little bit
Yeah, I was
frustrating.
curious.
So the thing is though, there's like definitions of what meets criteria for a surgical site infection. And a lot of it has to do with the time frame that the infection developed from when the surgery was. For that particular, so the hip infections are reportable to CDC through NHSN is the reporting. And they have really strict definitions. So even if we think that it came from another facility or activities they were doing at home, if it's within that definition and time frame, we have to report it as ours.
Oh, so it's a time.
Some of it. And sometimes was it in the culture? Was it diagnosed that way? There's the specifications for it are pretty lengthy from the CDC as far as what you have to report or not.
Yeah.
One of them was not reportable also, though. It doesn't get reported to NHSN. We only report total hips, total knees, colectomies, and hysterectomies, vaginal hysterectomies. So an appendectomy is not reportable, but we do keep track of them here to see if there's opportunities for improvement.
So there's a patient story, but are there any questions or comments about her report before she, and we can get to the dashboard.
Okay.
But, yeah.
So I got a quick question. So the Lean for Leaders, how are people chosen for that? What's their process?
So part of it has been these new leader cohorts that Julie, I think you started meeting with at the beginning of the year.
Last year.
Last year?
And Amanda's leading a couple.
And so it was like, as we're getting started with lean training again, we wanted to make sure that those leaders especially had the opportunity. Other folks who've been here have had training in the past. So it was kind of who had the time, who wasn't totally overwhelmed. So a lot of the senior leaders would say, yeah, it's a good time for this leader, this new leader, or that leader. We're on our 4th cohort now, and there are some old leaders, I guess you want to, some of us who've been around a while that are now going through, again, feeling like they want a refresher. And we've already got a list of people for the next cohort too that'll start in January.
So it's been well received?
Yes.
Yeah, well received.
Holly,
Holly.
with
So-
so many letters after me.
Yeah.
So impressive. Will continue to be remote.
Yes, she is going to be here on next Thursday. I can't wait to show her our facilities and so she can see KVH and what the culture is like in body. And, but she started on Tuesday, so started orientation.
But she'll be attending the Chartist.
Yep.
event, And we're hoping you'll be able to attend, all of you will be able to attend the networking event after discussion, and Holly will be available to meet then.
Yeah.
Before we get to the dashboard, we'll have a patient story, but any questions or comments about the report prior to the dashboard? Okay, so yeah, would you mind telling us, patient?
Yeah, so Julie asked me to share this. This letter is intended to let whoever reads it understand the outstanding character that Joseph Castillo, Joey, displayed in my time of need. I had an emergency medical situation while Joey was working at KVH Hospital in Ellensburg, Washington. It turned out to be a pretty serious situation, and I had to be airlifted to Seattle for additional care. Upon returning to Ellensburg, Joey let me know that because I'm a veteran, I would need to take additional steps to ensure proper billing. I was then made aware that he helped guide my friends who were there helping me through the paperwork to ensure that after this entire ordeal was completed, I would not be left in financial ruin. His guidance and care made the process much easier because he took the time to explain who to contact and what information was necessary. Finding people that take the time to explain things thoroughly and is not required by the job description, but is offered out of compassion and duty is a rare commodity worthy of praise. This outstanding quality had a significant impact on my life. Without his guidance and insight, I most likely would have had more health issues just due to stress alone. But because he did an excellent job, above and beyond the call of duty, I have been left in as good a situation as I could be. In this complex world, it's easy to overlook these things. It's easy to get swept away in the current and lost in the shuffle. I felt it was important to pause and praise Joey for all he did for me. If you're reading this, I hope this will help make decisions that bring Joey closer to your world, as I feel he will improve your world just like he did mine. Thank you to Joey, and thank you too for taking the time to read this. Sincerely, Tom Ritter.
What did you say Joey's position is?
He's a PSR.
He's a PSR, isn't he?
Yeah, he works, if you come to the front desk, he's usually on the left. In the morning.
That is awesome.
I think it just goes to show, and this is what we talk to all of our new employees about in the patient experience part of new employee orientation, is about how important every individual is to the patient experience and how much of a difference everyone can make.
So true. Yeah.
Do we have any gift cards we can give out or?
Scott's always buying pizza or something. I think reading it to the board and having the board acknowledge it is about his, and Julie, his supervisor, is gone right now.
I just sent it, when we got the letter right away, I went down and sent a copy of it and just with a note to his interim supervisor, Jill. The name was, we don't always get letters like that.
Not in your department, no, so that's really nice.
All right, thank you for sharing that, Randy. So the dashboard then. Everybody's had a chance to review the dashboard. Hopefully, Mandy, did you want to call our attention to?
Well, I'm real excited at the fall risk screening that our 3 primary care clinics, internal and adult medicine, family medicine Ellensburg, and family medicine St. Elm, all are above the target for the first time. That's really great.
It's a clear trend. in all areas.
Yes, and that, I believe, has come about from the lead providers in the clinics really partnering, teaming with their MAs and making sure it's clear that they expect them to get that information and work with the patient on that. So that physician leadership is what I think you see there. Or provider leadership. And they're working on that with the diabetic foot checks.
So one thing about this dashboard, going back to the governance committee, they asked me to show some public information from our hospital that our board looks at. And so Mandy and I talked about this dashboard and I shared it with the governance committee. They thought it was really interesting. And then the 2 items on here that my analysis, you may not all agree with it, but I felt 2 things that the board oversees and makes changes a lot are the care and service reports that we receive, and then also the workplace violence events. Because I also mentioned the fact about how we have the security officer downstairs that Julie helped us get, and we voted to do it. And those are the 2, I think, the 2 largest things in the dashboard that the board oversees things. That was one reason why we developed another CAT scan in our organization, because that way the care and service report allowed us to know that we needed another CAT scan, since we only have 1 CAT scan machine in this county. And if there was an issue with one of them, we would have a backup on. We can also do a lot more CAT scanning. So anyway, that was another thing that was shared, because it's a part of our public meeting with the other hospitals of WISHA that meet in the governance committee.
Sure, yeah, thanks for sharing, Terry. Yeah, and if I remember correctly, Mandy, the workplace violence events, that's new to this year. We hadn't, maybe not.
I think we did it last year, but it was new last year.
New last year. Okay.
And this is the OSHA definition. It did come from the Washington Rural Health Collaborative, was pushing for that to be reported, and so they helped get that started in our state for a lot of different facilities.
So what's the threshold for reporting on that?
It's really, it can be verbal, and it does not have to be it's whenever the employee feels that it was workplace violence. Sometimes though, all of those events get reviewed by the security and workplace violence team. So there are times when the employee doesn't say that they think it's workplace violence. And it can be from another staff member or a patient or a visitor. But there are times when we'd go ahead and we do say, I'm sorry that you thought that was okay, that they swung at you or whatever, but it's not, it's workplace violence, so we're gonna count it.
Yeah.
It's the
So
number
that
of
could be like
incidents, not.
Patient on employee on employee, a visitor.
Yep.
On employee,
There,
all different directions.
yeah, in this case, there were 5. 2 of them were staff on staff. And they were kind of about intimidation or bullying. And 3 were patients being verbally abusive.
So they just more broadly, I should mention that, yeah, so this was new last year, not this year. But this is, as we've said numerous times, this is the tip of the iceberg of the stuff that they measure
Yes.
in quality. And so, and we review every year in the QI Council what's going to be on the dashboard, what's not. So if there's anything else that you guys really think we as a board need to know, this is going to be reviewed in QI Council, so please pass that on to me or Terry. And I know that quality is happy to show you all the data they have. If you have any other questions that doesn't show up on the data.
And that's actually a good point, Matt, because as the QAPI process changes too, the dashboard will probably need to change as we are having these higher level QAPIs. There are going to be some measures that come from that, but there are also things we're required to measure and report to the governing body. And so we're trying to figure out what is that going to look like and how will it come to you? And so we really would appreciate if there's things like, I definitely want to continue to see this from a quality perspective as a board member. Let us know so we can make sure that that's included.
Yeah, so like you were saying, any questions at all, because we're dealing with safety and quality with this dashboard and the QAPI. So consequently, if you have any issues or things that you think we should be analyzing as a board so that we can vote on it and increase our safety and quality, that is very important.
Yeah.
I did have a couple other things I want to point out.
Sure, and then, John,
Dashboard.
it's okay, go ahead, and then, John.
On that first page, I just wanted to point out that right under QI Council, it's the top middle metric. The name of that changed to better reflect what it's actually measuring. So it's measuring how long it took us to send out a referral that was initiated in a patient visit that we had. So it's not when are we doing something about referrals that come to us. It's when did we send that message out to the facility that we're referring to. Did I get that right, Stacy?
Correct. Before it was time to complete, and for us, completing a referral means we've gotten the note back from that outgoing referral. So what this is really measuring is the time the provider said, I want a referral to XYZ, and we actually sent the documentation for that referral to that clinic.
The other thing I wanted to point out is on sepsis on the second page of the dashboard, the top left. One of those failures was the antibiotic was given before the blood cultures were drawn, which we're probably okay with. It probably was, the patient was so ill, we felt like we don't have time to wait for this blood culture. So just know that there are going to be times where, yeah, we're not at 100% and we're okay with that because that's what was best for that individual patient. And that was true in one of these cases that month. And then the median of 32 for ECG is accurate. There were times of 67 minutes, 54 minutes, and 55 minutes. So it was a very unusual month with those cases being that long. This is only looking at patients with certain indications. When we look at adaptics and our EKG timing or ECG timing overall, we're about 12 minutes. So these are good cases for us to look at and outlier, but they really are outliers. It's not
This is
the norm.
specific to the emergency department?
Yes. I think if it happened in like CCU, if that indication happened, like stroke, you can have like the TPA timing where it's in the CCU. It's just rare that that's where you're finding that symptom. So it's not very common. And I could have that wrong, but I want to mention too that you'll notice on the median time to lytics that there are no patients with that received lytics. And I know Cody's been working, I'm trying to remember, but they're
Cody's
talking-
on.
Yeah, could-
Oh, Cody, yeah, I don't know if you want to talk about that, but about public outreach to make sure to come in when so a lot of times there may be cases where we could have given TPA if the patient would have come in when the symptoms started. So it's too long past the time. So I don't know. Especially correct me if I got any of that wrong about the median time to ECG, but I
And
think
is this median time from when they checked in or from when they had symptoms at home or whatever brought them here?
I believe the stroke is from the start of symptoms in the facility. Yes.
So as soon as they walk through the.
As soon as they walk in.
Well, but if they were in an inpatient bed and suddenly they're having stroke symptoms, then it's measured from that. That just rarely happens. He's not speaking up, so maybe I got it right.
John, did you have a question?
Yeah, I was just going to ask about the hospice hospice length of stay. I know this has been an ongoing challenge, but it's still remaining fairly high percentage that it, what this is telling us is people are coming to hospice really late in the game and not getting much of that service before.
And 4 of those patients were from one provider, so there's some specific education that they will be providing with that.
This is a tricky one because it's kind of a double negative, right? Less than 7 days. We want the less than 7 days to go down so the the stay is more than 7 days.
Yeah,
Am I
yes,
following
that's
that
right.
correctly? Okay.
We want the percentage to go down, which would mean the number of days that they had is gone up.
And it looks like our goal is about 10%. The dash line, if I use a microscope and extrapolate.
So a lot of the work that we do in hospice is educating the family, educating the patient what to expect. And if they're in our care for 18 hours, which is not uncommon anymore, there's not a lot of education you can do. All you're doing is crisis management and get them through those last hours rather than preparing the family. A lot of the work we do is chaplaincy, a lot of it is social work. A lot of it requires a great deal of trust, and it takes time to build that trust, and having a stranger come to your home when mom is struggling with her last breaths isn't ideal.
Is it a resistance to believe the end is near? I mean, it seems like what we're offering would be positive to the family. So I'm just looking for that disconnect between we're offering these and they're waiting to the very last moment to take advantage of this.
Part of it is denial. Part of it is it's hard to think about somebody else's mortality without thinking about your own. Part of it is providers where we go to med school to save lives, and it can feel like giving up. What I've told patients and families for years is rationally, if death is the only enemy, I always lose eventually. But I can do a lot about suffering.
Dr.
And
Martin,
the art is knowing which is the enemy.
isn't there, it seems like there used to be some very rigid restrictions about when patients could be admitted. And I think re-educating established providers, it was like 6 months or something, and there was.
It still is, but it's not rigid. It's not that you can be on hospice for 6 months. It's that when you're on hospice, you have 6 months life expectancy. There are some diagnoses, particularly end-stage lung disease, where they will slowly decline until they get sick and suddenly collapse. And you don't know when that collapse is going to come. So it's not uncommon to have somebody with end-stage lung disease on services for a year, 18 months, or even longer. Parkinson's is another one that's hard to prognosticate. Cancers, Alzheimer's, those are more straightforward. We know what the milestones are to look for. But that 6 months is really speaks to there is a benefit to time. And it's hard to like we've really served the patient if we have less than a week.
I've encountered quite a bit in interactions with people, discussions about hospice. In my personal life is that people think we're not that close, we're not that sick. So really, that's not for me, when really that's a great time to at least consider it and perhaps partake of it. And so how much do you think that comes into play, that they just
A
don't?
lot.
Okay.
And again, that's akin to the denial. Because I know I've got this horrible disease and it's going to take my life, but not soon. And that actually rises to the level of one of the worst jokes in hospice, which is everybody wants to be with God, but not tonight. And that denial, they wait till it is the crisis, and they're struggling for air rather than taking advantage of the education and support offered days and months prior.
And to follow that up, the next thing I hear is, wow, I really wish that I had accessed hospice sooner. That's a big regret of many people I've spoken with. And
It's quite interesting that a lot of the families that we get that are really the more ideal referrals, it's because they have previous experience with hospice.
so they know, they understand the benefit.
And the big thing I think they understand is that it's not giving up. which is the other misconception. We've done all we can do, we're going to pack it in. And no, we're just gonna work really, really hard with a different goal. We're gonna work really, really hard to address the suffering. So I find this, the idea that almost half of our patients are on less than a week is incredibly frustrating.
So is it educating the providers, is it educating the community and the family members, or a mix of both?
I was gonna say absolutely.
All of it.
Isn't it also true, though, that if the patient wants to still pursue curative treatment, that they're not eligible?
That's sticky. Hospice is reimbursed on a daily rate and is responsible for all of the care a patient gets while they're on hospice. And that daily rate is intended to cover nursing and medications. When the family starts saying, we want to get a CAT scan, they'll blow the budget. And the conversation that I like to have in that situation is, okay, we understand that this is a terminal process. We're treating based on the symptoms. What is it that we hope to learn from the CAT scan? What is that going to change? And a lot of times, that's all they need to think about. Other times they say, well, we want to know if it's something that we can fix. Well, in that case, we will support you getting curative treatment. That's not what hospice is.
If that were to occur while someone is on hospice, do they leave hospice for a time
Yeah.
to do that?
They revoke the hospice benefit and typically come back on hospice a week later.
And is it a patient's prerogative to
Absolutely.
leave and come back?
So, at that 6-month time on hospice, do we have very many patients that make it to the 6 months and then they do constantly come back to us?
It's a very bimodal distribution. There are a number of folks that are on service less than a month and a number of service that are on service for more than 6 months. At the end of last month, our mean was, I want to say 133 days and the median was 33. So it's a very skewed distribution. I obviously, I believe it's important work. I think it's some of the most rewarding work I've done in medicine. And it's frustrating to see the barriers to understand.
Maybe, it seems like there's a hunger for hearing more about this. Maybe in an upcoming board meeting, we might like to have a presentation about it. Sure.
Can I, I'm over here having a difficult time keeping, when we were talking about how excited we are about the QAPI work, this work around community-based medicine is part of what's just really coming to go here. Dr. Martin is looking to identify a half-time physician who will be in charge of all of our community-based medicine. Pulling together, we say home health and hospice like it's one thing. There are very specific requirements for being admitted to. We have our GMP program. We have our partnership with KVH. Somewhere I'm going to pause long enough for you to jump in and share your
I
vision.
was going to say exactly what you're saying, throw in palliative medicine and helping people to understand the spectrum of symptom treatment. When we talk about palliative care, a lot of people think it's the same as hospice. It's not, it's treating symptoms. So that's the patient who's getting chemotherapy and is nauseous and we're palliating the symptom. Palliate means palliating the symptom of nausea. The examples of palliative medicine that we all came across as kids were cough syrup and Tylenol. Not treating anything, just except the symptom.
So I would love to, as they pull this charter together and design the team, I think that would be a really great presentation.
Okay.
Would it be useful to do like a town hall for the community at some point? Advertise it and have a big enough space where
If only there was some place like Hal Holmes we could do that.
only, we have to search, but they're out there.
And looking at your report and comparing to this conversation now, this half-time position, that's for the community-based care side.
And hopefully that's someone looking for full-time work so we can embed them in one of these services like hospital medicine or primary care.
The other,
Yeah, that is, so they can
Fill out
start
the other
pollinating. Yeah.
And it may well be that other 0.5 builds to where we have a full-fledged palliative care consult service. It's not a possibility.
Andy, that was a very thorough answer on the hospice length of stay question. Thank you.
Thank you, Dr. Martin.
Anything else about the dashboard?
So quick question on the COVID employee exclusions. Right, so these are people who are vaccinated or these? are-
No, people who are positive for COVID and have to miss work, have to be isolated and miss work. I know we had, I think yesterday, we had no calls, which was great because we had 3 the other day where we had to exclude folks. But we are hearing people are out everywhere. So there's also a bunch of other stuff.
Nowadays, how long do they have to stay?
It's 5 days,
5 days.
as long as the symptoms have improved. They don't recommend the test-based return. So 5 days at home isolating from the start of symptoms and then 5 days with a mask.
when it starts up, what does that look like when employees are out? Is it
Well,
just,
it's already started. We've had some
okay,
positives, yeah,
I
You
imagine.
I
left
think
out,
so,
you
yeah.
left out RSV.
I was gonna save that for next
So we,
week.
Scott, did you have some?
I was just going to add that we're, the community-based medicine, we're really fortunate that we're able to offer that. And that's because we're able to offer it out of an RHC. And a lot of organizations, a larger hospital could not offer that service. They would be given it, and we're able to offer it because we have that, it's linked to that RHC and we have that RHC encounter rate for involving, otherwise you couldn't do it. So that's just another benefit of being critical access and having that rural health clinic option.
Follow up, the flu, is that just once symptoms are gone for some amount of time? There's not
Off the top of my head, I think you've got to be 24 hours fever free. It's like similar to the schools as far as, and the same as like GI. We have a
Take
whole,
quite the hit per person.
what?
It doesn't take quite the hit per person, like a COVID diagnosis. Then.
Yeah, and there's part of me that wonders, have we correctly isolated for rhinovirus or influenza all these years or not? But I don't think, I think I will get murdered if I suggest we keep employees out longer for things like flu and.
Yeah, if only they'd had the scrutiny and the ability to scrutinize like we do with
I mean,
COVID.
It was
When they came
fascinating when
on.
we were doing the biofire tests on our employees to see all the different viruses
It's just the
people
incidental
had.
findings.
Yeah.
Well, and the fact that they all went away when we started.
I don't remember Anna calling it fascinating. I think she had a whole lot of other words for it. It wasn't.
The other thing to your question is influenza has a long duration of illness. Typical influenza illness is 7 to 14 days.
Just a comment about that biofire test. It's a great test, but it's not reimbursed.
Unless it's for the clinician needs it
It's not paid, unfortunately.
ever.
Medicare just last year took all the biofire test money that they paid us back.
But
And
that
the
was,
payers don't pay it.
yeah,
I'm just saying. It's a great test.
that was not part of their diagnosis. The patients are testing in our staff.
test cost approximately?
$800.
That's what we
bill
We
the
charge,
patient.
it's
That's
about,
not the
it's about
cost.
$330 or something like that per test.
I don't think it gets denied when an emergency room doctor or physician in the clinic chooses to.
It did.
For COVID, they, yeah,
We did 1,333 biofires.
every single one back.
So they still have that test. Do we still have that test now?
We do, and it's, anyway, I just,
Because there's a respiratory panel and a gastrointestinal panel, and it's really important in some cases, especially with elderly people that you're putting in the ICU, whether they have influenza or COVID.
Do you want to get the insurance companies and the government on the line?
I would love to talk to them.
Try.
Good luck.
just, it's, from a knowledge perspective, it's a great test. Financially, it needs to be used very judiciously, and
I think it is now.
Yeah, it is. It's much, it's
Never
much.
intended.
Yeah, and then we have the Cepheid test to test for COVID. So we've got other means to test, but I mean, clinically, they love it, but financially hate it.
Okay,
Anyway,
anything else for Mandy?
it's exciting.
I'm only gonna toss it to you, Julie, if you promise not to be contemplate my own death.
I will not, I promise.
All right, I didn't know I had to make that a condition.
So I will just say September 19th might not be quite as infamous as January 6th in Washington DC, but it's probably pretty close here. So there we have our commissioners who went back to Washington DC for rural advocacy days. We had an opportunity to meet with Kim Schreier, and we also met with Senator Maria Cantwell, and we met with some of the.
You might be causing feedback on that, Julie. Can you bring the volume down?
Always good to
Yourself.
Better? No.
Coming from Kevin. Mute yourself. Do not turn the volume down.
Turn off the Zoom window, you have to hit the little X somewhere.
that better?
Okay.
One more time.
I wonder if I wasn't doing that before.
I don't know. I think it might be going actually from your hearing aid also. It might have a little.
Who knows? Okay. I think
Another important encounter we had was with some of the staff from the House Energy and Commerce Committee. And in to connect ourselves with that committee, we actually went and visited in Kathy McMorris Rogers' office. Kim Schreier is also on Energy and Commerce. But it's important to talk to the staff, and there's some stuff Energy and Commerce put in their latest bill about site neutral. It's not good for us, so we got an opportunity to tell them how much we didn't appreciate that.
So Dr. Schreier hasn't come around on that.
Her position is she's doing the best she can to manage that thing. Anyway, it was a whirlwind 3 or 4 days. These are some of the folks from rural hospitals that it's a tightly managed sort of situation when you get in those rooms, but it was a good sized crowd. So I wish it was there to sort of shepherd us around. Anything I'm missing?
Any pictures of trying to climb the fence?
No, we don't want to enter that into evidence.
I was walking.
Just pretend.
Maria Cantwell scanned the room and said, "This is the largest group I've had since COVID."
Oh,
So
Yeah.
we filled her conference room, and but no, it was great to talk directly with them and hear their thoughts.
Yeah. So that's that group. The other, some other things I want to share with you. I want to thank Jeff Yamada's team. They are working on rolling out badge taps. So I have a magical badge. I know people like Dee Dee are about ready to march them down to her office. But right now we are still.
My pen, I'm so
It is so exciting.
We have a workplace violence event here, right here in a public board meeting. But so they're rolling it out. I think people are really anxious to have it, but it is important that we have a successful rollout. And the other component of this, and Jeff, you are welcome to correct me. I just have badge tap. Our clinical folks will have what's called VDI, which allows them to go from room to room and their actual where they are at in CERN goes with them. So it's a much more complex rollout, and it has to be done very strategically and very accurately. So how'd I do, Jeff?
You're getting technical there. Awesome.
That's why I stopped.
For the record, I'd like to say that I am very excited about this, and I'll clap without a.
So thank you to the IT team. It's a lot of labor on their part, but they are much appreciated as they roll that out. I want to remind everybody that we do have the Chartist event coming up on the 6th and 7th. I understand from Dr. Hoppy, we have about 40 attendees. We can't have the entire board attend that because it is essentially a business meeting and we want to keep it candid and not a public meeting. It will be at Hotel Windrow, and at the conclusion of that, we are, however, the foundation is sponsoring a networking event at the Elf Kitchen. That would be great if you guys could all come to that. We have 10 members, I think, or so from the Rural Collaborative, and we're offering this to them at a very nominal fee.
Is that included in the 40?
Yes.
Okay.
Yeah. So it's about med exec, physician leadership, and peer review. So the 13th legislative delegation will be visiting on October 18th. We have a substantial thank you for Representative Ibarra, who funded a big chunk of the ambulance station up in District 2 and our lab remodel. October 18th. Thank you. We are going to be focusing on, we know Representative Dent is very interested, particularly in adolescent mental health. Dee Dee and her ED team are going to be talking about the impact that resources for mental health has on our ED, in addition to just the length of stay and what we're seeing there. We'll also be leaning on Stacy Botten and again Dee Dee to talk about OB and sort of the fragile nature of that. WISHA is still working on their ask for OB, so we're not quite sure, except heighten the awareness and make sure they understand that all babies should be born in Seattle is not an answer. So Michelle is pulling together some data that lists the inventory. So in the 13th, we have Samaritan and Moses Lake, Quincy, Columbia and Ephrata, and KVH. So we've pulled together sort of aggregated data of what the economic impact of rural health is in the 13th. It's impressive. It's, and I don't have the numbers in front of me, but it's hundreds of millions of dollars in revenue flowing through those communities and hundreds of millions of dollars in community payrolls flowing through those communities. In addition to the free care that is provided, the ED visits, the number of babies that are delivered, and clinic visits. By the way, we win in clinic visits. So Moses Lake has 66,000, and I think KVH was at 88,000 for 2022. So impressive impact that we have in our rural communities. And they're going to leave. We have a very limited amount of time. They are going to leave with our talking points and the KVH story in their hand. So, Michelle, did I miss anything?
You did not. I'm actually pulling that information together right now.
Okay.
It'll happen right here on campus.
It'll be, yeah, in this room. So again, we have 1 hour. We are hoping if we have a few minutes that we're going to use all of our time and that they can stick around and take a tour of the lab and maybe get a shot of Representative Ibarra with our huge 150-foot aircraft carrier sized piece of lab equipment, then we'll be able to share. So, more advocacy. Let's see. I just want to reiterate the QAPI meeting. It is amazing work, and the work that we have teed up. Not only did we lose control of these enthusiastic people, but they've been in my office with this work since then. They're actively working on it, and it's, sleeves are rolled up and they're putting their teams together, and it's really exciting work. And the QAPI in the past, I have this year sitting on my desk. It's on ledger paper. It's double-sided, and I think it's 16 pages. This is going to be like 9 projects. One of those projects is KVH ISO 9001. That's where the departments are back saying, everyone has to measure and monitor quality in their departments, everyone. That's all going to be done under the one QAPI of ISO 9000. So that we can get an update on that. How are we doing without having a 16-page QAPI that measures everything from a $30 million expansion to making sure claims go out, within 3 days. So it was really exciting. And, Mandy mentioned it earlier, this cohort of new leaders that we have, some of them were on the job for 1 day at that point. There was no hesitation. It is a safe environment. They are confident. And they know their business. So
I think some of us as senior leaders were a little bit like, oh my God, this is really huge. But Tony shared with me, he said last year it felt like, man, you're just like dragging this out of people to get them to come up with their QAPI plan. And it just felt like a chore, like something, we had to do sometimes compared to this where they're people emailing like, hey, this is how far we've gotten on this already. Like there's a real excitement. And I think it's because it is the work they are already doing, want to do, feel like is really meaningful. So very exciting.
I do want to mention that we are, and I don't believe Amanda's. Okay. I do want to mention that we are going to arbitration on a WSNA issue. Our contract calls for 3 internal grievance steps. The first one is with the direct manager, the second is with the senior leader, the third is with me. If we do not resolve the issue in the 3 internal steps, it goes to arbitration. In this particular case, the request is that a step 1 corrective action be removed from the employee's file. So we will be taking that to arbitration. You see, I also want to acknowledge that exchange that we've had with a community member who has concerns about Dr. Dawson's exit. Amanda Scott has conducted an exit interview. I just want to invite the board to seek Amanda for whatever information they feel that they need in order to adequately address those concerns. So Amanda's put a lot of work into it, has a number of documents, original documents from the provider, from the community, and then also her notes about the exit as well. And then you all should have a letter. I apologize. I think it came a day after the last meeting from another community member who is suggesting that closing practices is something we need to reconsider. So, and construction, Ron. So I asked Ron to provide some updates for the construction. There is a folder called Cluster of photographs out there that they update on a daily basis. So since I found out about it, I'm out there. I feel like I'm stalking these people because they update them. But this is their
paparazzi.
yeah. So are these going to move along?
Yeah, I can
There we
do
go.
it if you want.
There we go. My only ask is that they stop digging holes and just start filling them in because they had a big backhoe out there digging more holes this week.
I think that's the foundation under the MRI.
Stop it. So, on schedule, on budget with the revised budget and revised schedule that we have. So yeah, exciting.
Great.
And I'm happy to answer any questions.
And Amanda, as you mentioned, Amanda's not here tonight. She couldn't make it. But her report is in here as well. So I think Julie would be happy to respond to any questions about that if she can.
On the 3rd paragraph from the bottom, where it says KVH declined to participate in the Rural Collaborative Retirement Benefit. Could you explain what that was?
Yeah, so one of the values that we received from our participation with the Rural Collaborative is they contracted with vendors like laboratory vendors and IT vendors for better pricing than just a standalone rural hospital can get on their own. This year, we will be moving our dental program over to offering that the collaborative has negotiated on behalf of all of their members. One of the things that they negotiated a couple of years ago was a new retirement plan where we have Corebridge or Valak, whatever it's called now. They have a different offering that they negotiated. we looked at the cost to our organization. Some hospitals had significant savings. We did not have the kinds of savings that some of the collaborative hospitals had, so we've waived that off. That move, we may save some money, but that's very disruptive to the employees. So we decided that wasn't where we wanted to spend our capital.
It was actually slightly more expensive to
Not
move.
according to Amanda's analysis, yeah. So, but it, very small. Yeah. So.
Thank you.
I'd like to ask a question about career development. The nursing workforce development program is open to KVH nurses and employees seeking to become nurses. Does this mean that BSN programs, there's
Yeah.
associates pursuing that? Okay.
And I understand we had our first
We had our
taker.
first taker and he was thrilled. It's one of our nurses in the emergency department who received his bachelor's of science in nursing this year.
Can you give a broad kind of explanation of, is it like full tuition reimbursement? Is it just some credit towards tuition? How
Want me
does
to
it
try to
work?
speak to this?
Well,
Where's Amanda?
we can tag team.
Yeah.
Go ahead.
So it is a set amount of money, the $5,250.
That's our IRS limit.
Okay.
Right, and this is a reimbursement after they receive their degree.
And is there any time commitment to KVH after they receive that money? They could do it and then resign the next day, or?
Yes, and like, obviously, that's not that we hope they don't do that. But there is a commitment up front, so they have to have worked here.
Okay, all right.
They have to have been here, I believe, 3 years and be a 0.75 FTE.
5,000 plus is substantial, really substantial.
They can, I believe after a waiting period, they can actually go back for that advanced degree. So up to 2 degrees.
So if we can get staff who are thinking about, getting their BSN, we've provided for that, our staff that has their BSN and can move on to their masters as well.
Where's the closest place you can receive a BSN?
There's a program in Yakima. Well, Yakima has,
Oh, you can do something else.
oh, you could do it all online.
It's all online. Okay.
If you already have your associate's,
Yeah.
starting
Okay.
fresh.
Yeah.
Then it's Yakima.
It's Wazoo.
Yeah, I was gonna say WSU has a Yakima
But if
campus.
it's online, and that's even more.
Lots of options.
There's a lot of options out there right now.
I don't think there's any clinicals when you go from an AA to BSN.
Yeah, there's usually some type of project or
It's
some
not
job shadow.
practice necessarily.
That was a specific ask of our WSNA, and we were happy to work with him. You can see how it's working.
I had a question for Amanda about the unique applications received. I don't know if you can speak to it all, but it said 271, which is almost 100 more than some of the previous months. Is that a positive sign that more people are reentering the workforce and starting to hopefully?
I know I contributed 40 of those with the risk manager position that I posted.
Oh, I thought you were applying for something.
No.
That sense.
No, but the risk manager position, when we posted it, I think because it was remote, I had 40 applicants.
No, we are seeing much more activity in the workforce than we did before. And frankly, I think it has a lot to do with our attention to the benefits and Amanda has a super team in terms of just managing those and getting the word out.
And we've talked about it, I think, a little bit before, but still, so we had 16 employees hired in August, it looks like. And then from the text, it looks like 11 were internal. So does that mean we had 5 people new to KVH?
I do not answer to that.
Or
I think I
16
owed-
new
I
and
think I
11
owed that
transfer.
to you 2 or 3 months ago.
I will pester her about it next time I
Okay,
see it.
all right.
I feel like she's, I might be remembering this wrong, I feel like she has spoken to that before, and the hire did include internal. But that'd be a great
I'm
question. for
inclined to
us
believe
ask.
it includes internal, but I hate vagueness.
Yeah, okay, we can check in for next time.
Okay. Anything else for Julie or Amanda in abstention? Thank you very much, Julie. Then we move on to operations, and we'll start with Dee Utley, Chief Nursing Officer. Go ahead, Dee.
Thank you.
my report's on page 32 and 33. And I think first, I'm just very pleased to say that we have Cody Staub signed on as our ED and urgent care director. And there he is. He's even got his picture on his Zoom login. He's been in the job about 2 weeks. Last week, he was able to attend the Emergency Nurses Association's National Conference and General Assembly that he's been very active with for years, even at that national level. So it was great to get him to sign the offer letter and then leave me. But we've got a nice transition planned, and I'm very happy to support it and excited for him to start. You're going to probably hear the word QAPI quite a lot in this next year, I have a feeling, because I can say almost every area that I wrote a few notes on or had my team write notes on includes our work that was identified at our QAPI session the other day, with the emergency department being added as our volumes increase, and just looking at our overall operations. We have new leadership with Dr. Schmelzer and Cody on board, and that will have a lot of projects in this next year. Because we are hoping to, see 70 a day is what Julie's predicting.
Well, Dr. Schmelzer, recognizing that a major remodel of the ED is not on the board for 3 years at minimum, he asked us to think in terms of 70 patients a day in the emergency department. And I think everyone at the table agreed it's not just more of the same. We need to think more about the patients we have today. Probably the low hanging fruit, though, is we've got a ton of equipment and supplies out there. How can we better utilize the space so that it's a more efficient looking emergency department, and that in itself should help improve.
So we are currently working on just what Julie was talking about with our equipment and supplies and how we can best use the real estate that we have. So just stay tuned. We've been averaging about 50 a day these last few months consistently. We're also looking at staffing and how we can augment our staffing matrix for a department that's grown by a good 20%. Other things, like I said, I think almost everything kind of touches QAPI. Julie had talked about women's health. I know we're anticipating having the OB hospitalist group brought on board, and how that is going to look. I know the staff are very eager to work forward to making that a very successful implementation. But I'm open for questions.
Questions for Dee Dee? Go ahead, John.
I don't know if you can speak on behalf of Amy's thoughts here. The construction, preparing for them to move inside the building. Walk me through a little bit of the disruption and how it sounds like you've been doing a lot of brainstorming to figure out solutions, and anything you want to share.
I don't know all of the details because I've not been attending her meetings, but I'm going to start. She has been meeting with her staff and really putting the onus on them to talk about their workflow and what it's going to mean when we actually break through the walls and we have to have rooms down. I know we're looking at what types of patients we can move out of surgical outpatient to free up the rooms for the patients that really have to be there. For example, if you come in and have an outpatient CT scan that you need an IV started, you usually go back to an SOP room, you sit in a nice recliner, you hang out in the room, the nurse comes, starts the IV, and then you get, taken over to CT. We're going to be utilizing our lab space, and the nurses will still, be starting the IVs, but just how could we, where else could we put them? Another example is our medical outpatients, that those are kind of those scheduled, frequent appointments. What types of appointments can we utilize other areas? And we're looking at wound care. We did this during the COVID response. So her staff know how to do that. So they're already starting to venture out and, look at these spaces. What are the supplies we need? We have increased some staffing to help support her during this time. Because we're not going to have the rooms, and our goal is, of course, that volumes will not change.
Terrific. Well, thank you. And yeah, I appreciate the thought that's going into this. I know it's a complex.
Her team is very, very engaged, excited. We know it's going to be disruptive, but we also know what it's like, that light at the end of the tunnel. I think having Dave Swarry involved is huge. I know I mentioned him last month. And this is another. This will be a QAPI. This whole, how do we best not only get through this next year during the construction and the remodel, but then what are we gonna do when it's all done? And how's our process gonna look?
How long is peak indoor construction? How long are we holding our breath for here? I think of it.
Conclusion of phase one, I believe, is scheduled for April.
6 or 7 months of.
Yeah.
And then hopefully they'll start to taper off. And eventually be done. Thank you.
Okay, so are there any other questions for Dee? Thank you very much. Rhonda's not here tonight.
Rhonda and her daughter are having an out-of-town adventure over the course of the next 10 days.
Okay. Hopefully you guys have all had a chance to review the report. I'm not sure if you have any questions, if other people might be able to respond. We will talk a little about some of this executive session.
I had a question, maybe Scott or Jason, just as a general sense. Just looking at the imaging, how many images do we do a day? Is that X-ray, MRI, CT, ultrasound, or is it just MRI and they talk about imagery?
It's everything. All of the, all of the modalities. Yeah.
And are we doing more than 200 a day of those combined?
I'm sure we are.
And I just asked because it looks like on any given day, we're getting orders for more than 200. So I wasn't sure if we were slowly building up a bigger and bigger backlog, or if we're able, it's a lot of work, but we're able to kind of stay on pace.
I think just the MRI is pretty backlogged right now.
And we knew that kind of the portable trailer wasn't going to have the throughput as the new machine will and stuff. So.
But we have been, are we still running on Saturdays?
I know, I think
They
they're
run it-
doing some Saturdays.
And they run it late. It's
To try to-
it's usually running at 5:30.
So, and the basis of my question was just, for our community, are we able to keep up and get people in a reasonable time frame? Or are we getting further and further behind? That was kind of the point of my question.
I can say, speaking from a clinic perspective, I think we're getting patients in quicker here than you see in facilities on the west side.
Okay.
Imaging usually runs for some of the modalities, maybe a 2 to 3 week wait. Echo, I think, is as cardiology has gotten busier, that has gone out, but it's still significantly shorter than what you're seeing elsewhere. And we're actually starting to see patients outside Kittitas County.
They're coming because of that, because they can get in.
It's quicker.
ER has been driving some of that also because many of the with these ER volume coming up.
And obviously, by definition, that's not planned. That's, they just got to fit them into the stream. Okay, thank you.
Excited for the new MRI.
Yeah.
Okay. That's it for Rhonda's report. Then we'll move on to Stacy Ray. And Stacy, by the way, thank you for the Gemba around rapid access again. I know it was very illuminating for me and
Yeah.
the other board members. So thank you.
You're welcome. My report starts on page 46. I want to talk about page 49, the graph. So what I did add is for the month, the August new patients per clinic. Just so you know, this is how the clinics are divided out in Cerner. So the volume for FME not only is FME, but also includes dermatology and the orthopedics clinic. So I thought it'd be interesting for everyone to see where those new patients are showing up in our system. Other than that, laboratory moved yesterday and this morning. So they are out of rapid access. They're in their home in dermatology, organizing their space, and rapid access is now working on setting up those 2 extra exam rooms and then that 1 extra space in there. Other than that, I'm happy to answer any questions.
Questions for Stacy? Go ahead, Jeff.
The MA program seems to be very successful. How's the retention, or is it too new to have a sense of retention? Because I think, like we talked about it during one of the Gembas, I think it also excites you when we go to the next level of their education also and get additional,
The retention, it has definitely improved since we put the program in. I'd have to defer to HR on how well that has been. But what we're also seeing with that program is staff are being, when they do that program, they go through multiple clinics. So they have the experience at orthopedics, they can see dermatology, they can see women's health. And then it really helps them decide where they want to end up in the organization. And with the growth that we've had, we may not have the clinic you want right now, but give us a month or two, we probably are adding providers and growing that we can get you where you want to go.
And then I know Michelle hired one of our very first graduates, Alicia.
Mhm.
Like, to be her assistant, so that I think we're retaining the majority of it.
And I think the tuition program for nursing probably will be really successful in this because I would say almost close to half of our candidates express an interest to either go into nursing or become a PA or do something else in the medical field. And this is their first step into working in the medical area. So I think the tuition reimbursement is going to be really exciting for those MAs.
When is the site visit to Mason General?
That is scheduled for October 12th.
Where is Mason General? Where is that?
I'm like, I know it's about a 3-hour drive.
Shelton, Washington.
Thank you.
Other questions for Stacy? All right, thank you, Stacy. Next up, we have medical staff, chief of staff, Dr. Hoppy. Dr. Hoppy, go ahead.
Yeah, all right, thank you. My one-page report is on page 50, I believe. And so far this month, we had 3 applicants up for a reappointment and 1 new initial appointment in the PEDS locum department. And so it's kind of a short list, which is a nice break from what we've been dealing with lately. So if anyone has any questions, I'd be happy to answer them.
Has everybody had a chance to review these on the online system? All right. Then do I have a motion to approve the MEC recommendations for appointment and reappointment?
Right. Go ahead.
So moved.
All right, so motion from Erica,
I'll second.
second from Terry. Any further discussion? Hearing none, all those in favor of approving this list of recommendations for appointment and reappointment, please say aye.
Aye.
Right. Unanimous. Thank you very much, Dr. Hoppy. Anything else?
I just want to kind of reinforce what Julie said earlier about the Chartis event, October 6th and 7th. I think it's going to be terrific. We've got a great agenda planned, and we're looking forward to having some great discussions and learning how to do our job better. So just wanted to thank the organization for the opportunity.
Great. Thank you very much, Dr. Hoppy. I think it's great to get other providers here to participate in that, and it'll be really good for MEC, I believe. So thank you.
Can I just mention the other piece of the engagement with Chartis was a review of our bylaws. So I believe Dr. Hoppy very, very quickly handed those off to Dr. Thomas. So he has a red line copy with some recommendations from Chartis that they'll be working through and will eventually make its way to the board.
Great. Great. Thank you, Dr. Hoppy.
Thank you.
Any last questions for Dr. Hoppy before we move on? All right. Thank you very much, Dr. Hoppy.
Thank you.
All right. Next up, our Chief Medical Officer, Dr. Martin. Go ahead, Dr. Martin.
Report is on pages 51 and 52. 2 brief notes. One, in Stacy's report, you saw that we did not have coverage for rapid access for the 30th. That's been corrected. Actually, just one comment. I've done enough damage to the agenda already tonight, so I'll take any questions.
It's important stuff. That's okay.
It feels like we're recruiting high school athletes, dermatologists online for 2025.
We are trying to get new graduates. It's interesting. When I was training, typically you started practice interviewing in your second year and really looking seriously at last year of residency. Now the standard is they are signing contracts 2 years before graduation and expecting a small monthly stipend to not go somewhere else. It's a very, very different market, and it's changing as we're learning it. And that has been a lot of the challenge we've had in recruiting. It's also surfaced in the locum tenentes we've had to use. 6 months ago, a shift of a locum tenens obstetrician would set us back $2,500 to $3,500. That's up to about $4,500 now. And it seems like it's changing every week. Every time we get a new candidate presented, the rate is higher.
We did have some, I will just say though, Family Medicine Clallam hired a 2024 grad, and she's zooming in for their provider meetings, they're inviting, I mean, they're really trying to incorporate and build that team even before, and I think she's gonna come do some, shadowing, so a lot of enthusiasm.
Given the culture of that clinic, she has to bring something for the potluck.
She does, yeah. They have a potluck question in there, set, so.
And then I want to offer my congratulations to Shannon for her promotion. I wasn't sure if you want to speak to that at all.
It reflects the growth of our staff. It's a testimonial to Shannon's work that we've kind of become a referral center for other medical staff services coordinator. We had a site visit from Newport, Perry County, where they have somebody that wanted to see how we do things. We've had a team up from Mason. The best estimate is that it's probably one medical staff services coordinator, one FTE for roughly every 100 providers. We have 220 some credentialed providers at this point. And so growing, recognizing the volume in that office, recognizing the expertise. Shannon's been with this organization a long time. She's earned every bit of that.
Yeah, she was the one who first trained me how to read the files way back when. Oh, that was great. Any other questions for Dr. Martin? So Dr. Martin, there does seem to be a real interest in seeing a presentation about hospice, palliative care, all these other sort of community services, either here or at a community event. So just let's just keep that front of mind so we can, when you have all that free time.
Keep that down to 90 minutes.
There's a lot of interest and there's a lot of interesting stuff happening. So anyway, I know you're very busy, but at some point it seems like the board would love to hear. Yeah. Thank you. Great. Anything else for Dr. Martin? All right, thank you very much, Dr. Martin. Next up then, we have our CFO, Scott Olander. Go ahead, Scott.
Thank you. The report starts on page 53, but if we would turn to page 56 to look at our stats, they'll tell some of the story for August. Lines 1 and 2, you see below budget on admissions and patient days for the month, and that will be reflected in the revenue that you see. You also, if you drop down to line 21, you'll see a positive number there on observation days. So we're exceeding, there's a shift from inpatient to outpatient continues. Line 7, below budget on deliveries. That's impacted our overall revenue. One area of concern, as I mentioned at the Finance Committee, is the average length of stay for the month was 4.4. We really need to be at 4 days and below. And Jason advised the Finance Committee that since the health emergency ended, our overall length of stay is below that 4.0 day, but this was a challenging month for, so that's just a number that we need to pay attention to. A lot of our providers and staff were on vacation, and so surgery volumes, lines 11, 12, and 13 were below budget, or below what they're running. Inpatient was below budget, GI procedures below budget, and then outpatient procedures exceeded budget, but we've been running a 40% positive variance on outpatient surgeries, and our positive variance was less. And then, as we talked earlier, ER continues to be busy, 5.5% positive variance for the month, year to date 6.8, and over the prior year 15.3. So ER is busy. Clinic was below budget on visits due to vacations. And you will see if we jump back over to. Yep. Yep.
So if you'll look at the year-over-year change on line 30, which is adjusted patient days, again, that's that statistic where we start with inpatient days, but then bump it up or factor it up for our outpatient. You can see we're up almost 20% when we adjust for outpatient year over year, which leads to line number 36. We're seeing some significant just raw increases in expenses, but when you look at it compared to the amount of business we're doing defined as adjusted patient days, we're actually managing those costs very well. So, you know, it's easy to get fixated on inpatient. That's somewhere around 12% of our business or something. So this is the best surrogate we have for overall volume.
So if we'll now jump over to the P&L on page 59, you see the variance on inpatient revenue, outpatient revenue, and what is a little surprising is professional fee revenue was way over budget, and that is on the third, I think the third paragraph, we talked about a reclass of professional fee expenses that had been reported up on the outpatient line. And so this is just when we've reported urgent care revenue in the past, we've just reported a combined number as outpatient revenue. And so we've broken it out now. So that's the reason for that shift in revenue. But overall, revenue was below budget, as the stats would indicate. Other operating revenue was, we had a same grant for about $37,000, and so which caused us a positive variance on other operating revenue. But the good thing about other operating revenue was the 340B revenue was pretty much right at budget, and that's and it has been right at budget for the last 3 or 4 months. And so we the work that Nasser and his pharmacy team are doing with the 340B ESP is paying some dividends. Expenses, professional fees over budget. Some of it was related to bringing on new anesthesia group, and then also locum expenses to staff, women's health, internal med, and probably peds too, I believe. And then we had some catch-up expenses down on the purchase services line related to Cerner, about $543,000 of prior month expense flowed through this month. So overall expenses exceeded budget by $563,000. We are still able to report a positive operating income for the month of $168,000. We had budget for almost $2 million, so a negative variance there. Year to date, $2.2 million operating income, a negative variance of $4 million. Non-operating, we're, in spite of all the construction that is ongoing, we've not had to pull money out of the LGIP pool to pay for it. And so we're earning additional interest income that we had not expected. And we had an unrealized gain on the investments that we have, which contributed to part of that. So, but year to date, a nice positive variance there of over $1 million. And so net for the month, $447,000, and year to date, 4. And let's see, revenue cycle, despite all their struggles with Cerner, had a good month. They collected nearly $12 million in receipts. And our days in AR came down a little bit, and our days cash went up. Days narrow came down 1.6 days in aggregate to 1.4 million. Days cash increased 2.8 days. So not a bad month, not great, but positive. Questions about August financials?
Any questions, Scott?
We have a capital request for telemetry system of $832,000. This will replace the all of the telemetry throughout med-surg and ICU, and it will expand the number of patients we're able to monitor in those units by 4. It will also increase the number of the telemetry patients that we can monitor in the ER. We currently have 5 rooms that we have tele in, and then we have 3 temporary tele units. So we'll increase all 9 rooms in the ER. We'll have telemetry, and then we'll have some additional portables. And then in addition, we'll have the ability to monitor. One of the units will be able to go into our MRI unit, and while patients have an MRI, they will have can be monitored the whole time. So this is the existing telemetry system we have is almost 19 years old, was purchased in 2004. And so it's at end of life. And
Okay. John or Bob, you have anything to say about the expenditure request?
No, we both supported it. I think it's good.
Yeah, and I met with Scott and Jeff, and we went through the whole system, and it's definitely needed. It will also fix some dead spots, some zones. It's all proprietary equipment, because I know I'd asked if they looked at some competitors, which they did, but that would require essentially tearing out stuff, infrastructure inside the hospital walls and ceilings and replacing that, so it was not efficient. So the Philips was the best. And then the boxes are X2 to X3. So in the ER, they're all going to be upgraded to X3s. And then I think the other ones will be upgraded as part of something else. But it's, you know, and the other thing that they did, I asked about the warranty, the service contract was $36,000 a year after year 1. And I think we came to the agreement that really it's electronics. If it's going to fail, it usually fails pretty quick. So the idea is we're kind of going to self-insure, if I understand.
I really want to thank Commissioner Ward for challenging us to think about just automatically going to these service agreements. So they all sat around and talked about it and decided time and materials was the way to go with this. So that I appreciate you asking us to rethink that.
And Ron Urlacher, who will be responsible for servicing, that felt very confident in being able to service it. So
Any trade-in value on the current stuff?
we're going to get about $21,000. So that nets off the purchase price, but the amount we're asking to request is $832,000.
I think Dee Dee in the emergency department, this would be a nice upgrade. It sounded like there's a lot of positives as to this new equipment, what they'd be able to do.
It's just increasing the number that we can monitor at once.
Prior, we're having to make choices who gets monitored.
It's triaged.
Yes, correctly. So this will eliminate that. So yeah, it was a great discussion. I really appreciate everyone taking time to answer the questions and show me how it worked. So I came out fully supportive of it this time, and ideally we get hopefully at least 10 years out of it. If we get another 19 and it's still working great, then that really is very, very cost effective for what it does for the patient. So yeah, I support it, which you could consider.
I'd like to just add, I really want to thank Jeff Holdeman, and Cody was also instrumental, because this wasn't just like a couple of meetings. This was a lot of meetings, a lot of documents, a lot of understanding all the letters and numbers, and really doing the walkthroughs and talking with the staff. And I'm glad we took the time and we did this right.
Yeah, unfortunately, I didn't get to meet with Cody, but I threw a lot of questions at Jeff, and he had a lot of answers. So it was clearly well thought out.
With all of our meetings, they are experts.
So thank you for taking the time to get so prepared. Appreciate that.
Okay. John, you want to make a motion?
So I make a motion to approve this capital expenditure request for the Philips telemetry system.
All right, Bob, you want a second?
Yeah.
All right, second from Bob. Any other questions or discussion? All right, all those in favor of approving this capital expenditure request for the Philips telemetry system, please say aye.
Aye.
Very much. And, you know, a couple months ago, when Vicky resigned as CNO, she kind of had a smile. And there's kind of, I got the sense that there was some kind of weight being lifted. I know what she, I know what she feels like. So I just wanted to thank the board that it's been a real honor for me to serve as the CFO these last 5 years. And I'm grateful for the support that I've felt from the board and Julie and the senior leadership and all of the hospital directors. And I've really been fortunate to have just a really good group to work with. And I'm excited about this digging into rev cycle. And but anyway, thank you very much.
Thank you, Scott.
Yeah, I think, don't we need to have you a patch on your jacket for being a CFO of a rural hospital during the coronavirus?
Merit badge.
And we're still here.
And we're still in business.
So, you know, yeah, I know that, I know the whole board really has appreciated working with you for these years, and you've done an excellent job clarifying some difficult concepts for us and really illuminating some things. And you've done an excellent job sort of getting us through some tough, sort of rocky times. And we're much stronger for your leadership in that position.
I'd be well served. Jason's going to be great.
Appreciate that. And your new job description is getting blood from a stone or something?
Think about manna from heaven, fishes from loaves, reimbursed for wildfires.
Well,
You know, as Scott was creating the new job description and kind of going, I think I just wrote my dream job kind of thing. One of the questions he did ask me was, do I have to go to board meetings? And I said, no, you don't have to. He was in, so.
Is that a have to question or is it a get to question?
Yeah, that was, I think voluntary attendance he's in for.
well, there's an executive session here tonight, but I'm not going to join you.
That was the thing he told me as he walked in.
We get to Kentucky and split?
Yeah.
Well, we could put the vote off till after. So we do have a resolution here, and as it says in the resolution, I mean, Scott, you've done a wonderful job. And the good news here is that, Jason, we have every confidence in your ability to take on this position. And as tough as it's going to be not to work with Scott, I know we're all looking forward to working with you, Jason. So we have a resolution here, 23-03, that will designate treasurer for the district. You guys have all read it and reviewed it. And are there any questions or comments or anything before we move to a formal motion? Julie, anything else we need to know before we?
No, sir, I have so appreciated working with Scott, and I just feel so fortunate that he's going to be in the revenue cycle position, and I'm surrounded by a tribe of CFOs. So.
Okay, so resolution number 23-03, do I have a motion?
I would move.
Okay, motion from John. Second? All right, second from Erica. Any further discussion? Hearing none, then all those in favor of resolution number 23-03 designated a new treasurer for the district, say aye.
Aye.
Guys have it. Congratulations, Jason.
Congratulations. You have to stay for executive.
All right. Exciting. Next up, anything, I can't ask if anybody has anything for Scott now, right? I have to ask if has anything for Jason. Questions? All right, Jason, we'll drill you next time.
Thank you.
Thank you very much and congratulations, Jason. All right, next up then we have our community relations report. Michelle, you're up.
I am. This is a hard one to follow. Congratulations, Scott and Jason. Other than the report, there are two things that I wanted to update you on. One is a congratulations for Julie, our CEO. We recently received notice from Becker's Health Review that she has been named one of the 2023 Critical Access Hospital CEOs to know. So that's a congratulations, Julie. We all know about the skills that you possess, but we're going to share that with the community. And I'm also going to take the angle of Julie's a great business person and CEO and leader, but she's also a great human, and she does a lot of things that people don't know about for the community and our patients. And I'm going to try and highlight some of those. And the other thing I wanted to just let you know, one of the things we heard from the staff was just during the SOP survey was needing more communication, getting more information on how different activities relate to one another, why we're making changes, why we aren't making changes, things like that. So starting this Monday, we're going to every month on the Monday after the board meeting, we're releasing what's called the KVH huddle. And it's going to be sent electronically. We're trying to keep it to one page, 2 at the max, just really covering things, what happens at the board. So for example, we'll talk about the equipment that you just approved and what we're going to be using that for, giving strategy updates, different improvement projects, where they stand, what we're doing, general KVH news, like the transition between Jeff and Jason, and the promotions of Cody and many of our other managers, and then just some training and event information. So that's something new that we're going to try. We're going to get that rolling, and we're going to do the same type of thing specific to providers as well, because some of the information they're looking for is a little different. So the huddle this month, probably the providers next. And I apologize for my dogs in the background.
Glad it's a dog.
Yeah.
Two of them decided to play right when I went out. I'll take any questions.
Any questions for Michelle? Go ahead, Jeff.
How are the farmers markets been going for our KVH booth?
The farmers markets had been going well. I'm not sure if you are aware, but my outreach coordinator was involved in an accident en route to Bite of the Bird. And so that's kind of put a halt for the immediate one. We had one planned a couple days after that, hoping to get things smoothed out and back for the last 1 or 2 in October.
Hopefully Alicia is doing better now, so.
Yeah, she's got a road in front of her.
Yeah, it's so sad to hear about that, but I'm glad she got good care.
Yeah, me too. Any other questions?
Everyone just note, as it says on here, save the date for the KVH Appreciation Banquet on December 2nd. Please put that on your calendar.
Please do.
Anything else for Michelle? Thanks, Michelle.
Thank you, guys.
Education Board, yeah, go ahead, Julie. Oh, sorry. Education and board reports. Mandy, if you wouldn't mind, just for the record, note that Carrie and John both attended Rural Advocacy Days in DC. We have an upcoming WISHA annual meeting on October 22nd, 23rd. That's what I was looking at on my phone. So that's coming up. I'm going there. They're going?
Yeah.
Anybody else, if anybody else wants to attend or is planning to attend, just obviously let Mandy know. No old business, new business. Now we're going to have executive session. Following executive session, we're expecting there may be a possible action following executive session. We'll break into executive session to talk about real estate and personnel, which is under RCW 42.30.110 B&G. I think we'll need an hour. So let's take a brief break and then return start executive session at 7 and return at 8. Plan to return at 8. Anything else before we go to executive session?
Who's joining us for executive session?
Who's joining us for executive session?
Jason, Julie, and I think that's Dave. Yeah, please.
Jason, Julie, and Dr. Martin? All right, sounds good. All right, thank you all for attending, and we'll see you back here
No
at
floating.
8 o'clock. Thank you.
Thank you, everyone.
Yeah, you can go later.